Hi everyone. The following is a talk entitled How to Appraise an RCT in 10 Minutes, which I've given to thousands of students and residents and clinicians over the last 10 or so years, especially those who are just starting to dabble in evidence appraisal. My goal is to show you that appraising an RCT, or a randomized controlled trial, is not as difficult as it appears, as long as you follow some really simple approaches and understand some basic concepts. After listening to this talk and practicing this approach a few times, you'll easily be able to do a solid job of appraising an RCT in 10 minutes. And at the end of it, you get a one-page overview consisting of approximately 30 or so words and a single comprehensive table of results. Ironically, the talk is about 40 minutes long, but I guarantee you by the end of the talk, you'll understand that basic evidence appraisal is a lot less daunting than it seems. If you wish, you can get access to an interactive iBook or a simple PDF that goes over much of the content by Googling UBC Wiki Evidence and clicking on the links at the top part of the page. Hopefully you'll find it all useful. Thanks in advance for listening. So, our objective is for me to work you through a process of creating a brief synopsis of a study using a format to the one that I'm going to outline to you guys. Okay? That's the thing, and I'm going to show you how I do it, and it's how most people do it once we do this. So, it's basically evidence appraisal for dummies. And I mean that in the nicest of ways. I don't mean that you guys are, it's just the way that we want to do it. So, the reason that evidence appraisal is so important is it informs the decisions that we're going to be making on a regular basis. It is way more important than you learning how to use a stethoscope. I would say that even if you were family docs. I would say even if you're any healthcare provider. Now, there's a few circumstances where it's really important to be able to use a stethoscope for certain things. But in general, being able to do evidence appraisal, being able to understand evidence is way, way more of an important skill than being able to do some aspects of physical assessment. Because the most common thing that we do in medicine is we give out prescriptions. It's more common than surgery, more common than talking, more common than anything to do with psychiatric things, way more common. So the problem is it's really tricky because there's so many studies out there. There's so many journals. And whenever I talk to healthcare providers about this, I say, I just don't have time to look at everything. And I agree with you. You don't have time to look at every article. And so you got to find people who you trust and respect who do this. But you do have to understand the language or the approach that's taken. So I realize that you don't have time to do this for every study, and we're not expecting you to do this. But what I can do is hopefully guarantee you that by the end of the program, you will get pretty competent at doing this. Because right now, if I was to give you a randomized controlled trial, and I said, is that kind of, and I said, appraise it, is that kind of how you'd feel? If I just give it to you and go, so by the way, that is, right, where is it? So that's the RCT, and that's you. So I don't want you to feel like that. That's just sad. Because you can do whatever you want. That ain't moving. I want to make it a lot easier than that. Or would you maybe feel like this? Going, I know what I got to do, but I just can't do it from here. And then when you feel like either of those two pictures, then you just go, I give up. So what I don't want you to do is give up. And I can tell you, it is not difficult. It is actually quite systematic in the way we do it. So, it's all about creating a simple process. So I can do this in 10 minutes. I guarantee you guys can do this in 10 minutes. The whole purpose of why we do this, if we could just believe everything in the study, that the conclusion was exactly right, the numbers are being presented properly, blah, 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 then we wouldn't have to do anything. But it's not about that. And it's not about that people are trying to be devious. The problem is that humans do studies and they report them. And so when you have humans doing it, it doesn't necessarily provide there's always a level of bias associated with it. So when you see a result of a clinical trial, you want to know, can I trust it? And so the whole process that we're going to go through is how much trust can you put into the results that are being shown? So that's your job. Because if you can't trust it at all, I hope you wouldn't incorporate it into your practice. If it's just a crap trial that's got so many flaws that the conclusions are not legitimate, I hope you wouldn't include it. But maybe you need to include that in your practice if it's a new study. So what I'm going to do is work you through a study that was published actually more than 11 years ago. But it serves a very useful purpose of how to think about this process. So it was published in the New England Journal of Medicine, and it's called The Effect of Intensive Glucose Lowering in Type 2 Diabetes. So if I was to just give you the paper, it looks like this. 15 pages, 4,500 words, 4 tables, and 3 figures. If I got you to just like read it, it would take you at least 22 minutes, even if you were reading it at the speed that you would read a trashy novel. If you were just to read it, it would take you 22 minutes. But I don't want you to read it. In fact, I never want you to read a study from the beginning to the end. That's of no value whatsoever to anybody. And it's incredibly boring. And if you were to do that, it'd just put you in a coma anyway. So I want to make it so that your process is hopefully interesting and you search with a reasonable approach. So what I want to do is show you how to take this awfulness and simplify it. And what we want to do is, this is the journal article. It's got 15 pages, 4,500 words, 4 tables, and 3 figures. What I want you to be able to do is to change that into something that's much more simple. This evidence synopsis where it's 1 page, 10 to 30 words, and 1 table. And it'll give you all the information you need to understand what's gone on with a study, how to use it clinically, and so on. So that's my goal. I guarantee you now, we've been doing this since the program started, 5 or 6 years ago, I guess. And at the end of, even in the end of second year, the students are really good at doing this, but you just have to learn the process. So we look at a study by identifying what are your needs. Is it important enough for you to read? I'll get you to search a few key terms in the paper, looking for those, and then get you to ignore most of what's in that paper. That's the beautiful thing about this. You can ignore almost all the words in the paper. Then you got to look at who was studied, what happened to them, and then ultimately, if you care about the results. So here's how I do it. This is how I do an evidence appraisal. When I get a new study or look at a new study, in fact, I did this exact thing today. A new study that looked at getting people to different cholesterol levels and did it have an impact on things like stroke. And I looked at it, and I was able to gather all the information I needed out of it in about 5 minutes. And it's really simple if you know what you're looking for. So here's this is an abstract. You guys, I'm sure, are familiar with what an abstract looks like. Here's what I do. I look at the title. If that title is of interest to me, and it's why when you write papers, you should make the title interesting, I look at it and go, am I interested in that? If this had something, like I don't work in the area of oncology and it wouldn't be that interesting to me, it's a very interesting area, but I wouldn't be interested. But this is an area that I've worked in, I've written about, I think it's really kind of interesting. So I'd read the title and go, yeah, I'm going to go a bit further. If not, I just stop, because it's not a topic that I'm interested in. For sake of argument, at this moment, all of you guys are very interested in this topic. So if it's not of interest, you just stop. But we got to go forward. So what I do is I look at what were they looking at? And in this case, have you guys heard of hemoglobin A1C? What's hemoglobin A1C? Have you guys heard about it in this program? So what is it? Yeah, so it's a measure of glucose in your blood over time. So in this case, here's what they did with this. They said, we're going to either intensively lower glucose to an A1C below 6%, or we'll target an A1C of between 7 and 7.9. Now, whether or not you know it, that's actually an interesting question, because should we be more aggressive in getting people to lower their glucose? So I read that, and I went, okay, that's an interesting question. They may not have answered it well, but it's an interesting question that I need to know the answer to. But I don't just stop there looking at the abstract. I then look at what's the outcome. Because if it was, how good are they at lowering A1C? I cannot tell you how little I'm interested in that. I want to know if I lower A1C to a lower level, more intensive therapy, does it actually change important outcomes? And in this trial, the primary outcome is a composite of non-fatal MI, non-fatal stroke, or death from cardiovascular causes, which is an important outcome, at least for most people. And I then look at, like, how long were they treating them? If they were only looking at like a 1-month trial, diabetes is something that one would be maybe dealing with for years. If it was 1 month, I don't really care. But this one was over 3.5 years, so that's at least a reasonable amount of time to think about it. So I keep going. And then I look here. I don't look at the conclusion because I think it's true. I just look at the conclusion and go, this is likely being presented in the best way that the authors wish to present it. So in this case, I would read, the use of intensive therapy to target A1C levels increased mortality and didn't change cardiovascular events. That's really interesting to me because when this article came out, practice was to use intensive therapy to lower glucose. And I'm going, if that is true, if I do this and I increase mortality, I need to stop it because it's not doing anything. And in fact, if it actually is doing something, it's worsening outcomes. So if this is real, I need to know this because it would fundamentally change what I do. So if I've gone through this and I'm still interested, I would sort of keep going. If not, I don't even bother going there. I just look at the abstract and I've done my evidence appraisal because I don't need to go any further. Again, I'm assuming that you guys are now interested in this and you want to find out what the story shows at the end. So what I have to now figure out is that conclusion true? Or I can never know for sure, but can I actually trust it? So how do I do that? Let's recap first. I look at the abstract, look at the title, look at what was studied, look at the outcomes, and then read the conclusions. Really a simple process. Then, what I'll encourage you guys to do is I would ask that you download the PDF of this article, whatever article it is that you're going to look at. And the reason I do that is you now have it in, if you've got a Mac, and if you don't have a Mac, why don't you have a Mac? But then you can put it into preview. You can search words in that PDF. So, for instance, the very first word that I would get you to type in is that. Why do I get you to type that word in? Because our job is to try to say, we want to look at a whole bunch of things to make sure that there is as minimal bias as possible. So why do I type the word random in here? Because if you don't randomize them, it could be, I could go, okay, you and you and you and you get drug, and then you and you and you get another drug, and I'm now influencing what's going on. And I shouldn't be able to do that. So we randomize to either one treatment or another, or one treatment or placebo. So that's one thing we look for. Now, almost everything I'm going to give you, not at least tomorrow, next week, it's a randomized trial, so you don't have to look for it, but it's there. So we do that. And if you search for that, it said they were randomly assigned, so now you're thrilled. We also put in the word blind. Why do you think we do that? What do you think we put in the word blind?
We want to blind either like the researcher or the participants or both to what groups they're being assigned to.
Yeah, and so my question is going to be, guess what?
What?
No, why?
Why? Because then we would be reducing bias that way as well.
Because?
Because the researcher or the participants won't know either what they're getting or...
And why would that you sort of gone around in a circle.
Yeah.
You probably noticed that as you were saying it, right?
Yeah. That just improves, I guess it's like similar to randomization where it would just
yeah.
improve, like we would reduce the ability for the researcher to, again, pick and choose and just like improve the characteristics, I guess.
So if it's an unblinded trial,
yeah.
What does that mean?
That means that like researcher might know which groups people are going into, or participants know what group they're in.
So why that's true. So why would it be good to blind them?
To reduce, like, people might act differently depending on what groups they're in, depending on like the study. Researchers might treat people differently.
Yeah. So there's a whole bunch of biases that can come from that. So we want it to be blinded, and that means. And you were correct, you said it could either be blinded to the patient or the researcher. If it's both, what is that called? Double blinded. And there's also a thing called triple blinding, which is the person who's doing the statistical assessment is also blinded. So we, as much as possible, we want it to be blinded. So we did that in this study, and it said this. So this trial is not blinded. Do you know why it's not blinded?
I guess it would, like, it's something that the researchers would have to know which group participants are going into.
Because?
Which might, just because it's not something that they can, like, hard to explain. They would have to know the outcomes, I guess, or they would have to know which group, because they would have to be able to tell what group participants are in to be able to make a
what if it was a drug versus placebo group study? Could you blind that?
Yeah, you could blind that.
So, but you couldn't blind this.
No, because I guess it's conditions that we're looking at, so it's not.
Yeah, so we're randomizing people to different levels of intensity of glucose treatment, and that would be very difficult to blind.
Yeah.
One of the reasons that we try to blind trials is when we look at the end point is because if you believe that you're going to get a response from something. So let's say it was placebo.
Or yeah, the researcher might think that the intense one is going to be better, so they're just going to.
So they might have a bias there.
Yeah.
So what type of endpoints do you worry about? Subjective or objective endpoints if it's unblinded? So if it's more objective, so give me an example of an objective endpoint that would be something that it's pretty obvious. What's that? No. Oh, that's a measurement. Yeah, that is, but measurements can be relatively subjective sometimes. What do you think? What's a really quite objective endpoint that you wouldn't go, that you couldn't kind of fake? Yeah. So death is, you don't go, well, they're a little bit dead. Or they were sort of dead and got better, right? So if this was a study that looked at mortality, it might not need to be blinded. It would be better if it could be, but it doesn't have to be. Now, if it was more subjective things, what would be a subjective endpoint that you'd want to make sure is blinded? Yeah, so pain would be a subjective endpoint. So you see the difference between, yeah. So if it's pain, you kind of want it to be blinded, for sure, if it's drug versus placebo. In this case, it's impossible to, because you told me you couldn't do it. And it's okay because the endpoints are pretty hard endpoints. So it's not blinded. So now we do this. We write the word allocation. This is even worse, even more confusing. What do you guys, any of you ever heard of allocation? Okay, I'm going to help you with this one because this is tricky, and I guarantee you most of you will get it wrong when we do it next week. Allocation is, as a researcher, I should not know what the next person is going into. So if I could open up an envelope and look at, oh, I see that person is going to be put in the placebo group. If I thought the drug was really useful, and I like the person, I might go, geez, I don't know. I don't want you in that arm. So allocation to which arm the person is going into needs to be concealed from me. If it's not, I could bring in a bias to that. Does that make sense? So that's not blinding, that's allocation. And we'll talk more about that as we go along. But when I type that word in that study, there's no mention of it, and quite often there isn't a mention of that sort of allocation word. Doesn't mean it didn't happen, but it's just not there. Then I type in the word intent, and I also help you with this one because this is trickier. So intent, I'm looking for this, an intent to treat analysis. And I'm going to go over this a little bit in the IA with you again. What it means is, if you are randomized into one arm or the other, whether or not you take the treatment, whether or not you stay in the study, whether or not anything is, you are analyzed as if you did. So it's called the intention to treat. You had the intention of being in the placebo arm. You had the intention of being in the treatment arm. You're going to be analyzed. So you're analyzed to the group that you were randomized. Make sense? And in this case, they said, yeah, we did do, the analyses were done on what we call an intention to treat process. And then I look for the word follow. And what that means is, I'm not looking for how long they were followed. We already know how long the study was. Remember what it was? 3.5 years. So that's not what I'm talking about, follow. I'm looking at how many people are still in the trial at the end. So how many people were lost to follow-up? In this study, 0.5% lost to follow-up, which is a pretty small amount. If this was a trial of schizophrenia, like 30, 40, 50% of the people who started the trial 8 months ago, we have no idea where they even are anymore. And it makes it very difficult because that's a large loss to follow-up. So these are the 4 or 5 basic criteria that we look to go, if you want these to all be done properly, and if you have all of this done, you would suggest that the trial has a lower risk of bias than if it had any of these things. So we're happy with that. We're not happy with that, but it's something we can't do anything about. We don't know about that. We're good with that and that. Now, so we've got 3 checks out of 5. What does that mean? It just means it's not as good as 4. And 5, I'd be even happier. So I don't know whether that sort of process should make you feel like this or like that. What I do know is the more checks, the more confident I am in the biasness of it, if you will. So that is basically how we look at bias. And then we look at one more thing, which we look to see who funded the trial. So we just want to look where the money is going. And this is a list of all the conflicts of interest that the people had. Most of the researchers were funded by the drug industry, and you cannot get away from that if you do diabetes research. They are all going to be funded by the industry. Did you have a question? Just push the button for a second.
Where do you usually find that section in an article?
It's usually somewhere at the end.
Like in the references or just?
Not just before the references, usually.
Okay.
So the nice thing about it, though, even though all the investigators had conflicts of interest, this entire trial was funded by the National Institute of Health, or almost all of it. Because this is a really important clinical question that needs to be answered for the population. So it is not bad to have conflicts of interest, they just need to be declared. So every drug company is involved. Every drug company has not fingers, that's the wrong way. Every researcher has involvement with drug industry who may or may not benefit from the results of such a trial. There's not much we can do about it, but at least you're aware of it. So we always look for where the funding is. So I talked about blinding. It could be single blind, it could be double blind, it could be triple blinded. Allocation concealment. What that means is the researcher here is enrolling this patient into a study. If it was a study of morphine or physiotherapy, could we blind that study? Yeah, you could kind of fake, you could do sham physio. No, honest to goodness, you can do sham. I don't know if you know, we do sham surgery. So where, like, the first one I ever saw done was where they thought that tying off a mammary artery helped angina because when they did the surgery, this person's symptoms got better. So they randomized people to either cutting them open, tying off that artery, or just cutting them open and then sewing them back up. Found it didn't do anything. We've seen the same thing with knees doing arthroscopic surgery, that doesn't improve outcome. And so the way they figured that out is we did cut them open. By the way, they were informed and all that sort of, it wasn't just, okay, we're going to cut you open. So we can't blind that, but what we want to do is we want the decision of which arm this person goes in to be not made by the researcher. So we go off-site to a computer or something that puts them into that. But as soon as she gets told you're in the morphine arm, everybody knows she's in the morphine arm. So is that blinded or unblinded? Yeah, but there is allocation concealment. But it's unblinded. Now, if it was a study of morphine and placebo, you could allocation conceal it and blind it. The intent to treat analysis that I talked about is we put everybody, whether they completed the treatment, they got the wrong treatment, they didn't receive treatment, they died, lost to follow-up, all of the people. If randomized, then they're analyzed. Now, intuitively, one would want to exclude the people who didn't take the treatment. But if you do that, it leads to a randomization problem because now the trial is no longer randomized or truly randomized because we're removing people's based on whether or not they took the treatment. And it may be because the reason that these violations went on is because of the severity of the condition or the treatment or whatever. So we want to analyze if you were put in an arm in the first place. And if you start taking all sorts of people out, you power a trial to be able to show a difference, if it's indeed there. But if you start taking people out and not analyze them, it makes it more difficult. You lose power. You could exclude people, and just the exclusion could be a bias that's put into it. And including all people is actually more like practice, because when you give out a prescription, it doesn't mean people take it. And we'll get into a thing called a per protocol analysis, but we do an intention to treat analysis because if we go with an intention to treat analysis and we show that it's still an effective treatment, we are even more likely to go, we're happy that we think the result is true, because it's the most conservative estimate, which is why we do it that way. And then we look for loss to follow-up. If it's a large percentage of people, relatively speaking, if it's a very small effect but we've lost lots of people, then the trial's probably pretty useless. If the effect is quite large and the loss to follow-up is not that big, then we're happy for it. And then we also look to make sure there's not a difference between the arms in the number of people who were lost to follow-up. So to look for bias, we go random, blind, allocation, intent, follow, loss to follow-up, and conflicts. Much of the rest of the text, introduction, unless you don't know anything about the topic, just ignore the introduction. Unless you're really obsessive compulsive about this, just ignore the methods. Ignore the statistical test done, because no one, statisticians care. You should not care that much at all. And then the discussion. The only reason I read the discussion is I just want to see how the authors are spinning. And I don't necessarily mean that negatively, but I want to know how they're going to spin the results. Because then that'll help. Then I know what's going to be said in the press. Now we want to know who was studied. And this is really simple. You just go to Table 1. Almost always, Table 1 has the patient characteristics. You may not be able to see this, but this is the variable. This is, are they, their weight, do they smoke, how old they are. And here's the intensive therapy arm, right here. And this is the standard therapy. I know there are 5,100 people roughly in each arm. And then I look to go, are there any clinical differences between this? Are there way more men in one group or women than women? Are there much older people? Do they have different cholesterols? Do they have different blood pressures? Do they have different glucoses? And I just look to see, are they similar? So I look to see if there's any clinical differences between the groups, because that could bring in a bias. And then I also want to know, if I'm going to use this study, who does it apply to? So then I look at the characteristics, and I just bring out the ones that are relevant to me, so that I can create a picture, if you will, of who this person is. The average age is 62. About 40% are female. Some of them have had cardiovascular disease. They've had diabetes for 10 years. So I now get a picture of who this study applies to if I look at the patient characteristics. And that's all I do. And it's literally that quick. I just look who was studied. So I just look for the difference between the groups and the baseline characteristics. And then I've already talked to you guys a little bit about this, and I'm going to maybe spend a little bit of time in the IA activity. But you're going to see results presented in a couple of different ways. There's a thing called a risk ratio, and a risk ratio is literally exactly what it says, a risk. If 10% of people had a heart attack in one group and 10% had it in another group, what's the ratio of 10 over 10? 1. That's a ratio of 1, which means no effect. If it was 8% in one group and 10% in another group, what's the ratio? Or 0.8. Same thing. Yeah, so 0.8. That's all a risk ratio is. So that helps me figure something out. So 8 versus 10, that's a risk ratio of 0.8. And that's what we usually look at. Sometimes you'll see curves and a thing called a hazards ratio, which is just a ratio. So this is the number of people who had an event, and this is the years, and maybe this is death or something. And there's two curves. There's the intensive therapy and the standard therapy. And they get these events as they go along. And sometimes rather than just looking at how many people overall had it, we look at over time. And then we just do what we call a hazards ratio, which is the slope of those two lines. You don't have to follow everything right now because you're going to do it again and again and again and again. But a hazard ratio is just the slope of those two lines. And if it's a much steeper line, that means more people are dying more quickly. Now, what you want to do is go to Table 2 because it usually has the outcomes. Now, for some reason, they decided to put it in table 4. But in table 4, this is what we look for. A1C, 6.4%. A1C, 7.5. So this is aggressive control. This is less aggressive. And these are all of the outcomes. Heart attack, strokes, death, and so on. It's all in a table. And it gives you the numbers of people who had it. Their primary outcome was how many people had either a non-fatal MI or non-fatal stroke or death from cardiovascular disease. So or cardiovascular causes. They add all of this together. And usually the primary outcome is right at the top of the table. And there it is in all its beauty. And there it is in the other group. And what I do is build a table that looks like this. And you guys are going to do exactly the same thing on the board in the IA room. Primary outcomes. 6.9% of people in the intensive group had one of these bad things. 7.2 had it in the other group. We're not going to spend too much time talking about this, but this is the ratio. If you put this number over that number, it's roughly 0.9. It's not quite, but there's a reason for that. We have confidence intervals. All it is a range where we think the result is. It's somewhere between here and here. Because the exact result that we found here is 0.9. But it could be somewhere between here and here. So that's all it really says, and we'll spend more time, but that's what a confidence interval tells you. So the hazard ratio is the ratio of the slopes of the hazard curves, which we already talked about. The confidence interval just represents a plausible range of values for the effect, but not a probability of its magnitude. A 95% confidence interval doesn't mean it's 95% sure it's in there. Here's what it does mean. If you did the trial 100 times, 95% of the times, the confidence interval would include the true result. It doesn't make a heck of a lot of difference. We're still saying it's somewhere between those two numbers. And then I look at all death, add that in, and then that's a 22% relative increase. So death went up by 22%, but that's a relative number. So death was 5 here and 4 here. What's the absolute difference between those two numbers? 1. So death went up by 1% in the intensive group. Make sense? You will hear that mortality went up by 22%. Using math, can you see that 5% is 25% more than 4? Because if your baseline is 4 and you go 25%, that goes from 4 to 5. That's why 25% and 1% can be the same thing. So in this case, so is that a good thing or a bad thing? It's bad because it shows intensive therapy increases death by 1%. Those are the numbers. And we'll spend a lot more time going over this. We don't have to get it all. And then I just keep putting in all the things that are important. And I build up a table. So now I know what happened. Heart attacks, death, stroke, blah, 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 all of that. So I know what happened. We're almost like literally done now. Not literally. Does that mean I'm completely done? We've got just a couple more slides. But now that's all the data. We looked at bias. We've looked at the results. We've created a table. So we looked at the primary outcomes. We looked at the absolute numbers, relative numbers. We looked at the confidence intervals. And you guys will learn how to look at these and what they mean as we go through this. So we've got a table that looks like this with the numbers and so on of all the things that were important. But then you got to look for the adverse events. And adverse events happen to be in table 3. So we do exactly the same thing. We look for the endpoints that are, and if you could think about it, what do you think, if you were more aggressive at lowering glucose, you might have more hypoglycemia. So you look for the number of people who had hypoglycemia. You look for the number of non-serious and serious adverse hypoglycemic events. And there's more hypoglycemia, 10%, 10.5% versus 3.5% in the group that got intensive therapy. There were more serious adverse effects. There was more weight gain. We know that when we aggressively control blood glucose, we have to use medications. And at that time, you had to use medications. And on average, they increase weight. So 27% of people would gain more than 10 kilograms compared to 14% in the non-intensive group. So that's an adverse effect, because that's not what we're trying to, that's not an endpoint that most people would want. So we put all of those in this table. So now we have a table of all the primary outcomes, heart attacks, strokes, and so on, all the adverse effects, in a very similar way to what you do them in a very similar way each way. So what I've done in 40 minutes is, I hope, shown you how to take this and make something that looks like this. So those are the 5 criteria that we look for bias. That's who was studied and over what period of time. That's what the patients look like, age 62, female 38, and so on. And there's the table. You don't have to color code it, but the red is a bad outcome. Green is a positive outcome. And those are the adverse events. So if you were to look at that, so if you looked at those results, what would you want? Would you want intensive treatment or less intensive treatment? But you do get more death. There's a reduction in MIs, but you also get more hypoglycemia, more weight gain, and more serious adverse events. So I think you would probably go. I would not have wanted to be in the intensive group. I hope. Not for sure, but I'm pretty sure that should be convincing. So now we have to, so what I would do, and I'm not saying I would do it exactly like this, but now if you were a type 2 diabetic and you were seeing me and we're going to go figure out how aggressive should we be, I could say, well, we used to be aggressive in our glucose control, but at this time, this was the very first trial that had ever looked at it. We now have 2 other ones that they don't show harm, but they show no benefit at all. So I would say, but if I just had this one study, what I would want to do is let you know about it. I'd say, look, here's what happens. If I aggressively control your blood glucose for 3.5 years, there's a 1% increase in death. That's the absolute number. There's a 1% reduction in non-fatal MIs. There's a 7% increase in serious hypoglycemia. There's 0.6% increase in serious adverse events. And 14% more people will have a 10-kilogram weight gain. I have now got the healthcare provider understanding the information. The patient knows the information. They can make a decision. Now, some people might say, I still want it. I'm not sure why. There may be other reasons, but that's how we do it. So I know enough information to help you and I would hope that we both agree that you probably wouldn't want that. Now, you still may have other reasons for it, and then we could talk about it. So that's sort of how we do evidence appraisal. It's all about identifying if this is a study that's of value, look to the things that might invoke bias, ignore the rest, look at who was studied, look what happened to them, and then you got to figure out what happened to them. So I've tried to give you a very quick approach. I guarantee you can do this in 10 minutes once you get good at it.